So we are just going to have an informal discussion, charcha, rather than making it a very formal thing. Uh, and I would like to start from Dr. Agasha sir. Uh, as I said, that as an actor, as an artist, and as also as a psychiatrist and also as a teacher, how do you see the initiatives of uh, psycho-oncology or of supporting the cancer entire family and the role of media, especially the cinema where you belongs to, is going to, and how can you guide us what we should be doing? Yes.
Thank you. Girish, you have asked me a question which I can't answer in 2 minutes,
Okay.
but I'll try. Yeah. Let me go back a little. When psychology was new, every branch of life added a word psychology to it. From psychology of art to psychology of science, psychology of everything. This was during the Freud's time. Now, since pandemic, mental health चे दिवस आलेले आहेत. So one way, काय त्याला म्हणतो वाईटातलं चांगलं काय. So in a way it was good that we had pandemic. We suddenly became aware that health is not only physical. And in fact, if I have to share with you, if there is one health, health is only mental health. I know of no illness where a patient walks into doctor's clinic only with his body. Whether it's even common cold. Common cold is very nagging. जे बरंही होत नाही आणि स्वस्त बसूनही देत नाही असं. So all kind of illness have their dimensions. So if I understood by and why I went to films as his question, mind is not an organ. So mind is not in the brain, not in the heart, nowhere. You can't cut any organ and find mind. Right? Similarly, like you can't cut any instrument to find music. So you have to keep the instrument tuned so that it can create music. Keeping the instrument tuned is only one part. With that, if you don't know how to play it, then you can make noise also. So the idea of health is you should keep yourself fit in body and mind. And mind, therefore, is a function of body like music is function of the instrument. So the health care, when it pertains to whole body, we have just divided it for our convenience of understanding. Like even in physical medicine, we have divided the body in respiratory system, central nervous system. But as an individual, you have to have a synchronized and interdependent function of all these systems. And all these systems have a mental health component to it. So it's very, in fact, what is surprising is, if you don't lose your mental ability to appreciate, even if you lose a leg, no damage is done. In fact, if you see all Paralympics, all those who have lost a lot of physical organs, if they retain, something good about mind is, if you decide it can't be fractured, it can't be broken. It's up to us to keep it integrated, even if there is a bodily illness of any kind. And now this awareness has become, I'm glad that how an illness like cancer affects. So when we say this cancer is not only body cancer, is the clear. Unfortunately, I'll say one thing which some of you may not like. Our chief guest today, I don't know if you are aware of the caste system in India. You know, the high caste and low caste. You know. That caste system is actually more existing in medicine. Diabetes, cancer, hypertension, these are high caste. It is all. You can publicly talk about it. You can have groups, diabetes. Oh, you are on oral? I'm on insulin. That kind of conversation. Oh, I had 2 bypass done, but I went to Vaishnav Devi. And at the other end, there are illnesses like HIV, severe mental disorder, leukodema, depression, where you can't even tell others that I'm going to a doctor. So Pune patient go to Mumbai doctor. Mumbai patient go to Indian. Now if you meet your client in a party, he avoids you. Or if your friend is talking to you, when he goes out, his friends ask, "Kya hai? Problem ka hai?" So these kind of illnesses, so there is a whole range of illness like a caste system. So in a way, cancer, diabetes are lucky ones. Because they get more attention, even they get better funding. Because mind is invisible. So you can't. And डोळ्याला दिसतं ते खुपतं ना. Now this psycho-oncology is an opportunity for you to develop the capacity for inner eye. To treat illness, any illness, besides what your eyes are able to see, if you can't see the pain, the suffering behind it with the inner eye, no therapy is going to work. And more important, certain diseases don't affect only the patient. It becomes the family affair. And what is most important is, in our medical college, we are taught how to treat a disease, how to identify a disease, what are the causes of disease, how to treat a disease. But we are never taught how to treat a person with a disease and how to treat his family, how to do emotional management. And in our formal education is completely dominated by reading and writing, which are tools of thinking brain. But the tools for emotional brain are our eyes, ears, and that's why cinema is more powerful. To communicate love to you, I don't have to stand at the podium and say, "Excuse me, I love you." Not necessarily. While passing by, you can glance, and people come to know. And you also come to know. Sutti. So these languages are more powerful. And the reason I maybe shifted from academic research to cinema is because academic research keeps away those people for whom the research is done. And it is not communicated to them. You do research, present it in the conferences only in a language which people understand. Then it adds to your biodata. It gives you promotion. Then you write an article. It gets published in a journal. Journal sits in the cupboard. And only somebody once comes to refer to it. And people for whom that research, outcome of the research is important, they have never communicated the outcome in a language they understand. And it's very simple. Now, if somebody speaks French, you have to talk French. So this multilingual approach of cinema is much better because it has all the languages. Language of image, language of sound, language of word. The care we have to take is, like we choose healthy food, nutritious food, and exercise, we must choose nutritious entertainment and differentiate between junk entertainment. Junk entertainment is going to bring you to me, and I have to prescribe cinematic diet for health. So better be careful about your cinematic diet. It will add to your mental health whether you have any illness, I can tell you. And how to choose, that I am not going to tell you now, otherwise you won't call me again. Thank you.
Thank you. We are definitely going to keep calling you again and again. That's for sure. Now, Dr. Ranade, even on your website also you have mentioned that when you become a president, you wanted to policy making, formulation and all. So in terms of oncology and psycho-oncology coming together, how do you think the institutions like medical association should play a role? And you as a president of that, how do you foresee the plan?
Thank you. Sorry. Thank you, Girish. On a lighter note, I would say that you can still change your name from Girish to any one of Bhagavan Sri Krishna's names with the number of colleagues that you have around you.
Yes.
Also, I would like to contradict one small statement made by Sir. I know him since my childhood, and again I'll say not as a patient since then. Maybe now it would be required. Sir, definitely cancer is not something which is practiced only in the journals or written only in the journals. We are using all those things every day in our clinics, and I'm very proud to say that our clinical research and our practicing methodologies are at par with any other center in the world, right, even in this city. And I'm sure Anand would agree with me on this particular point. Correct.
When I made that statement, it's for the people at large, not people who are practicing it.
Sir, I just wanted to clarify that point so that the takeaway message won't be wrongly taken. Anyway, coming back to your question, it's a very nice question and the answer is very sad. I'll tell you, in 2003, I presented 2 papers on psycho-oncology in Europe, in ASCO, American Society of Clinical Oncology. And the attendance, even then, at clinical ASCO, which has an attendance of around 50,000, 7 people attended that oral presentation in that small room. When I became president, I tried to start a branch of psycho-oncology in 2015. And we decided that we would have a meeting, and we called for papers from students. We received 0 papers in the national meeting. So I would say that policy making is easier if the demand or need for policy is there, and maybe at that time those efforts were very premature. Now, as everyone is saying, that COVID has taught us a lot, that we should start respecting psychology, which I think psychology covers every bit of medicine, and every bit of medicine should have some kind of a psychological support as an ancillary science. I'll give you the difference between oncology and cardiology. In cardiology, there are n number of advocates of cardiology who will say what should be done psychologically, this and that. But apart from some other diseases, oncology differs that you are continuously there in the shadows of death. And death is something that we don't know what is beyond death, so we all are scared, and I don't need to talk about all these things to this audience. But whenever we are trying to come out with a policy, there are no takers. Government of India told us very clearly, you come to us with a program, with a module. We tried to do that through Pune University, I'm sorry, MUHS at that time. Nothing happened. Nobody took the programs, and we never were aware that we had to start with some kind of a basic education which should be there. It should be either MA Psychology or BA Psychology or MD psychiatry. I don't know what it could have been, but there were no takers. So policy making is easier provided there is need. Now I feel this could be the right time to do all that. There is another difference. See, I have a clinical psychologist working with me for the last 10 years. Each and every of our patients sees her. But the issue that is really bothering us is there are two issues. The first issue is the advice which is given to a patient who comes from a very creamy layer is different than a patient who comes from a slum area. Because the things that trouble them for oncology treatment are different. Secondly, prognosis. Now, there are two categories. Let's broadly say that people who can be cured, curable cancers, and patients who cannot be cured. And the strategies for their treatments have to be entirely different. I'm sure everyone agrees on that. And that could not happen if the prognosis of the patient was not told to the psychologist. So I think the harmony between a treating oncologist and a psychologist, psychiatrist has to be there. Dr. Shailesh Sogle, I haven't seen him here today, but we used to work with him. And once he was told the diagnosis, things used to be a lot easier. So I think these problems we have to address on the drawing board first and then come up with a suggestion for policies. The government is doing everything and we need to be more proactive and reach them. I'm sure that won't be an issue. And this could be a very good beginning for going in that direction.
Right. Thank you. As you correctly said, the program that we have planned for PG diploma in psycho-oncology, the first module we are focusing on oncology. Because a regular psychologist without a technical knowledge of oncology can't do counseling. That psychologists must know what are the types of cancer, what are the stages of cancer, biology. Interdisciplinary. Yes.
See, my suggestion is why can't we have some, see, we have tumor boards where we are supposed to be sitting, the oncosurgeons, medical oncologists, radiation oncologists. I think we also should make a psycho-oncologist sit in that forum and then take it up from there. And
correct.
We also have to, at the beginning, we also have to make it compulsory for the patients to attend those psychology sessions. They are so negligent. Two things they neglect. One is nutrition and second is psychological health.
Yes. Onco-rehabilitation is also a very challenging issue. Yeah, in fact, we are addressing that also. We have contacted few experts from UK and US who, one of them is onco-nutritionist and one is already here in our panel, onco-physiotherapist. So for the redevelopment, because when we talk about the improving quality of life, so it is not just medicine or the physical health, but like you said, the mental health comes first. If I am mentally fit, I can carry on with my physical pain. But if my mental pain is there, whatever fit I am, whether six-pack abs and all, I am not healthy. So mental health definitely comes first.
Since you opened up the topic of a physiotherapist and a nutritionist is going to be a part of this, one small suggestion, we are having them for the last 10 years in our clinic. But again, the nutritionist in India has a huge challenge ahead of him or her because all our diets are different and newer data is coming which supports actually those diets be used rather than whatever is being printed in the West.
Yes.
For example, use rasgira in place of quinoa, very small suggestion. And for a physiotherapist, use a cycle tube in place of Therabag.
Yeah.
Because those are the things, they are cost effective and better.
Yes.
So such things, I think things will evolve.
It has to be regionalized. Like today morning only when I and Dr. Sausen were having a breakfast, she has different taste buds throughout her life.
And genes.
And genes. So when I asked her how is it, she said everything is masala. So India is like everything. So she was knowing masala chai. Then we told no, here everything is masala. If you go order Chinese, that will also offer Indian version with lot of masala. So definitely that is a very valid point. Now moving on to Dr. Rajguru. It has been 55 years that you are into psychology field and in a different roles.
Yeah.
As a counselor, as an academician, as a researcher. You must have encountered multiple experiences throughout these 55 years.
Yes.
So I just have a simple question to you. How do you see the change over the period of more than half a decade, half a century And like when you started and what, so what are the changes and how, whether those, you think that those changes are positive or have some issues with that?
See, I first started in Calcutta. I was in Anthropological Survey of India as a research worker. And there I had a chance to work among the slums, Calcutta slums, you know. I was working on tailoring practices and personality development. And all that field experience, I was going door to door. I had administered a TAT, CAT, this test also. And that was, and I was knowing, I learned their Bengali. So I could work in these Bengali slums. Then Howrah station also I worked. I have learned a lot from this patient, how to approach them. Even entering the slum is not easy. So government, that was a government department. So our name and everything was nearby police station. They were keeping watch, our person is safe there. But to enter in the home, it's difficult. They think this white collar person, they have come to take some, our number and they will cut our ration, something like that attitudes are. But then it is our approach, how you approach the person. And I could easily do their work. 2 years I worked there in that slum. And I found what was actually there is City of Joy, some author has written the book on Calcutta. So that tremendous condition I have seen that time. And psychology also was very new field. 65 I passed out. After that when I came in army here, to here, it was a new field for me, but it was very challenging. Every day I was seeing n number of patients from 8 o'clock to 2 o'clock. I was not getting time because every patient we are testing, diagnosing, doing the follow-up also, and I was keeping the record. So one day it happened, Mrs. Gandhi rang from Delhi. One patient, she was not remembering. There was some, this patient is not allowed to keep the weapon. He was Sardarji. No, that is the religious aspect. And I just came in middle, so my senior advisor, Admiral Dinoto, he sent up, Madam ko bulao. Ma'am, ye patient yaad hai kya aapko? I said, yes sir, he's an MDP case. He was from MH Kirki because they were always calling me. Memory bank bolte the mujhe. So I brought out that record that he is a psychotic patient. So naturally he won't be able to keep the, so actually it was going to be a political issue. But within minutes when I showed the record, sir, he is a psychotic, he is not allowed to keep them, and problem solved. So in army, I had a lot of experience there, seeing the n number of psychiatric patients, their diagnosis, their therapy, even cancer patients, we had a big ward there. But they were coming to me for psychometry assessment, neurological testing. Still I was seeing them, they are so lethargic, they are getting tired. So I never did any test in one sitting. Because they were feeling so tired, I was calling, and I was never terminating without counseling them, relaxing them. Because I think it is a part of my life, my duty. So I really enjoyed seeing all the, now also when I with the patient, I am completely with the patient. And you learn from patient. Because patients are our teachers really. Everything is not written in the book.
Right.
Thank you.
Thank you. Thank you very much. Yeah, please.
Can I just add to that? As a bystander, I would say I have been now practicing for 27 years. There is a huge change in acceptance of psychology in our society, at least in people who are literate. So there is a difference. Earlier, psychologists, or I wouldn't say psychologist, but if a reference was written to a psychiatrist, वेड्यांचा डॉक्टर मला नको आणि तेच सगळे वेडे आय एम सॉरी बट दिस इज वॉट पेशंट्स यूज टू से दिस इज अगेन नॉट मेंट फॉर एनीवन इन पर्सन बट दिस इज नाही 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 तुम्हाला अजिबात काही मी म्हणत नाही.
नाही तू म्हणलास ते बरोबर आहे कारण वेडांना डॉक्टर लागतच नाही. दे हॅव फाउंड देअर सोल्युशन. जर वेडं व्हायचं नसेल तर आम्हाला भेटा अशी आहे.
पण हा ॲक्सेप्ट Another thing I have realized that many of the cancer specialists have also realized that for themselves they need treatment.
Yes.
Continuously we are under stress.
Yeah.
And yes, burnout is there, and we need something which will help us. And I'm here to say that I do see a psychiatrist. In fact, they say that my family physician is a psychiatrist, because we all need it probably. But
Yeah.
forget the joke. We have, as caregivers, I'm not talking about the caregivers which has been spoken in your module.
Yeah.
The doctors need, the cancer physicians, surgeons, they all need a psychiatrist. The patients need a psychiatrist. The caregivers need a psychiatrist, and the entire team also should have some sessions and some kind of, even therapy to come out of this. So there's a huge change. As I said earlier, maybe it was not the right time to talk about those things, policies. Now, psychology is well accepted. People don't think that there's something wrong with them, that they have to go to a psychologist.
Yes. Thoroughly appreciated this. Now moving on to Dr. Kopikar. Again, linking it to my personal experience of women empowerment, working with women issues, and I have seen at depth the deep roots of the issues which are there in the mind. And you have been into core of your activities are related to the breast cancer. So how was that your experience of 30 years plus, and what are the common issues? Like, because this is a very sensitive area when we talk about the breast cancer in public, and there are families, like if a wife is having a breast cancer, what that husband, mother-in-law, father-in-law talking in society, then the delay in, like Marathi मध्ये आपल्याकडे म्हणतात अंगावर काढणे, so late approaching the services, healthcare services at late. So what are the challenges that you have faced, and how do you suggest to address that, and role of psychology in dealing?
Yeah, so I think we understood the role of psychology very early in our practice, and I have also a first here where I worked with a psycho-oncologist in 2007-8, and she was trained at Bangalore in a Psycho-Oncology institute which was created there. And she worked with us for 4 or 5 years, and I think we understood the importance of psycho-oncology in various ways. So I would see a very close interaction between psycho-oncologists and oncologists. And they need to first start with teaching the community and the doctors, the GPs, then you come to physicians, and then you come to surgeons, and then to oncosurgeons and oncologists, that there is a role for mental, for a good mental, steady mental situation to cure any disease. And one of the most important aspects, and I just would add to doctor's comment in the beginning, that when a person walks into a room of a surgeon or an oncosurgeon, she comes with mental problems, and we should be there not to enhance her mental problems. And I think the physical state of the patient is as important as the mental state, according to me. So for example, if it is absolutely necessary, yes, a loss of an organ or a loss of a limb. If it is essential for treatment, yes. I mean, but then you should replace it. You can't let a lame person go without a leg, right? So similarly, if a woman comes to you, and I think this is an awareness that the psycho-oncologists can clearly create for everybody, as I said, right, from community to the doctors, that conserving the breast is important, because that adds to the mental stability of the patient. However much you give her counseling after that, that mental stability is not going to be the same. In a woman, that has been shown in various studies that the mental state is different. Or if a mastectomy is needed, she should have a reconstruction. Unfortunately, in my practice, the biggest hurdle ever since I started practice was to convince first the family, first the patient. Because as you know, in some parts of India, the father-in-law makes the decision for the patient what treatment she is going to have. So it's the question of first convincing the patient, because she has heard everywhere, oh, mastectomy is the best choice. Then comes the relatives, then comes the GP who is referring, then comes sometimes even the oncologists and the oncosurgeons, convincing them that even in certain situations, breast conservation is still the better option. Today, in fact, there are studies to show that survival is better in breast conservation patients than in patients who have had a mastectomy. That has also been shown. So, coming to your original, I think the biggest challenge for us was to, first of all, convince everybody. And today, I am happy to state that in our unit, there is a 80% breast conservation rate and a 85% reconstruction rate. And I think, and we have used Psycho-Oncology to see whether we are really doing the right thing. We do an assessment, we have a prompts, we have quality of life assessments happening, because we have a large number of psychologists working with us, and we have published this data where we have shown that women's satisfaction is much better with breast conservation or with reconstruction other than the mastectomy. So that's I think, if you understand. The other very important point here is, why do women not go for early treatment? What are they afraid of? First of all, they are afraid of the cancer. Second, they are afraid of losing her breast. I have had patients who have just let the cancer be there because she says, I don't want to lose the organ, I rather lose my life. Then you start having marital problems, you have social problems, all of that. I have heard many times a couple where the husband has left the wife after a mastectomy. Yeah. So these are issues that the community needs to understand, the surgeon, and unfortunately not only the community at large, but the medical community needs to be understood. So if you are using cinematic, I would suggest you make a film which shows the community that it is important to preserve organs. It's forget not only breast cancer. It has been shown you can preserve organs even in a limb cancer. You don't need to remove the limb every time. When you come up with these and the community comes to know, I'm telling you, your acceptance of the treatment will be better. People will come up for early diagnosis. Many of your problems will be sorted out by telling patients that, telling the community that cancer can be cured if it is diagnosed in the early stages. Second, you don't need to use your organ if you are diagnosed in the early stage. Yes. So if these are communicated well to the community and also, as I said, the medical community, it would be the way to go.
Yes, yes, yes. Thank you very much. I mean, both are very relevant points, and I can realize that with my experience, when husband used to hit wife as a domestic violence, and there are various experiences of the social workers working on them, that when they go to that particular woman that your husband is hitting you, so let's go to the police and we'll file a complaint. So she used to answer कि husband नहीं मारेगा तो कौन मारेगा, बगल वाला. So that was their reaction. So the woman believes that getting hit by the husband is a normal process. So that is the psyche complex. Yeah. So similarly, the body shaming and all, I really appreciate what you said. Now, yeah.
Actually, what the doctor was saying, that body image is very important for a woman. That's why I want to add here, she doesn't want to lose that image.
I want to be the devil's advocate here, that treating cancer, psychiatry, psychology has an importance, but at the same time, if a curable patient is not going to get cured because of limb preservation or any preservation of an organ, that's not ideal treatment. I'm not trying to say that there shouldn't be breast conservation, Anand. I agree with that. But at the same time, you clarified it in your first sentence.
You will not agree with me. You have to agree with the scientific community on.
No, that's what I'm trying to say, that there are norms of treatment wherein some person will tell, okay, sorry, the breast can't be conserved here. And let them decide that. Beyond that, whatever he said, and he clarified it in the first sentence, that very often it can be done. So please don't carry a wrong message based on that.
I said about 70 to 80% of women can conserve their breast. The 20% we just can't conserve. I don't advocate conservation in a patient who will die because we do conservation. But there are studies to show that even in certain extreme conditions, breast conservation is better. And there are studies to show that not only quality of life, but survival is also better. So wherever you can do breast conservation, do it. Where you can't do it, see that the patient is offered a reconstruction. She may not take it. 15% of my patients know, I'm very happy with. So what is the difference between the West and India is, there is a shared decision making. When you make a decision about treating a patient, you say, "Are chal, get admitted today, आज रात में मैं operate करने वाला हूँ. So this is what is the trend in India, which
Right.
is so bad. I have had patients who have come to me saying that, oh, I've been advised a mastectomy and I've been told to get admitted today only for a mastectomy in the night.
Right.
So this is how.
Yeah, there are 2 points that came up from the discussion is the treatment decision making as a part.
Should be a shared
yeah,
decision making.
and then secondly, the communication part of communicating it with this, and that's where Agashe sir's role, the communication comes into picture.
Sorry, I know I'm talking too much.
शेवटी सांगतो. Okay. Okay.
Let me ask one question to the audience. This is again based on data. Whenever a doctor starts talking to a patient, he asks the first question, "Kai hota hai?" And do you know how long the doctor waits for the patient to speak? Or patients to speak? Any guesses? Sorry? How many seconds? It's less than 2 seconds. The first question is immediately followed. Kai hota hai? The patient starts, bara hai na saga? You know, something of that sort. So the point that he made is so valid that because of pressure of practicing doctors, some wrong things are happening and we have to be careful about that. And communication, you are supposed to be a good listener and that we are not. Especially the doc. Maza boltoy.
Yeah. Now I would like to ask one question to Dr. Mahati. Getting from the experiences and from the experts, as an academician and as a researcher, what do you see that is to be done and where we are?
Okay, so thank you. So before I just answer that question, I was thinking about what Dr. Ranade was saying, right? I mean, psychology has taken such a long time to take off in a way in India. Immediately I remembered this. When I was 7, I decided I wanted to do psychology. And my parents laughed. And when I finally got them to agree to do my undergrad in psych, my dad was like, okay, let's just make sure that this chick is not going very far. We're going to have to support her for a long time. And then when I decided to do Psycho-Oncology at my master's level, my parents were quite certain that they'll have to marry me off early because I might not be able to support myself with that career. So from there to this point where there's a center for psycho-oncology that's being inaugurated, I think that, in the last 20 years, it's come a really, really long way. And like all of you have, observed, I think COVID definitely did amplify the need for mental health. So yeah, I mean, that's been very helpful in a way, I guess. But coming to the question about academics and research, so, I mean, see, I've already told Girish this. The issue that I encounter several times is that there is no inclination or desire to consider evidence-based practice. I think that one of the reasons could be that the sheer volume of patients that we deal with, we probably don't have the time or the bandwidth to also consume literature. The other issue is that we don't even have enough evidence in our own country. And for that, there needs to be appropriate training in how you do research. And I think that scientific inquiry and that respect for doing science the right way and then having the right avenue to present your work is another major issue that we encounter. But apart from that, I also think it's about how do you consume academic research. That is something that really worries me because often what happens is that we tend to read literature the way that we want to read it rather than understanding what is the real message that is being sent out to us. So often I'm asked to kind of teach how do you think research, how do you do research, and how do you consume research. But having said that, I would say that in psycho-oncology, at least in India, I came back to India about 13 years ago. And since then to now, we've come a very, very long way. And I'd like to take this opportunity to say, you know, there are researchers in Calcutta, there are researchers in Chennai, in Bangalore, myself in Hyderabad, and those in Delhi and, you know, in the northern part of India as well. There is research emerging in psycho-oncology. You know, and it's a range, right? There's a lot of work in quality of life. There's a lot of work on just the experiences. They use qualitative methods, they use quantitative methods, they use mixed methods. There is a lot of work. And even I was just telling Dr. Anade that, you know, there's a journal called the Indian Journal of Medical and Pediatric Medical Oncology, IJMPO. They've actually, I'm an associate editor, and they've actually decided to put up a special issue in psycho-oncology for Indian, readers. So research in psycho-oncology has come a long way, but I think that what is important in academia and research now is to stop saying, well, this is what they did in the West, so can we replicate those studies over here? Or this is the narrative of science in the West, what has happened. I think it's more important to take that pride and say that this is how it is in India, and this is how we're going to do the research, right? I think that need for pride is needed now.
Yeah, in fact, we all are we all are proud to say that Dr. Mahati is a part of our academic program that we are launching today, the PG Diploma in Psycho-Oncology. And along with her, there are 4 other experts in Psycho-Oncology, and there is only one trained pediatric Psycho-Oncologist in India, only one. She is Ria, she is here today, and she is also already a part of our program. So whatever few 30-40 Psycho-Oncologists, trained Psycho-Oncologists, they are already becoming a part of this program, and I'm very happy and honored for that. And that credit goes to Mahati for that, for getting all this connected to us. So now I'll sum up with the last question to Dr. Agashe about communication.
Kopika raised a very important point about communication. Now, what your experiences are, they are curable, people can lead a wonderful life despite having, so befriend cancer, which actually we have learned in Corona. Don't say I'm in fight with the Corona, I'm going to win. Befriend Corona. Let's live together and live together happily. If you don't want to leave my house, don't leave my body, stay there. But let us be happy, both of us. That kind of. And what you say, you said make a film, is now this is a living example. What you people know, the practicing people, general people don't know. And that's your complaint. And to communicate that, you have to use this. But then how to use that medium is very difficult. And I will give you 2 examples, very nice. Now probably all feature films, you have to previously show a short film on cancer, oral cancer, yeah? Which is so ugly, which is so that the idea is not to horrify you. म्हणजे इन्शुरन्स सारखं नाही तुम्ही मेल्यावर तुम्हाला फायदा होईल असलं मार्केटिंग नाही करायचं सो दिस इज व्हेरी डेंजर एव्हरी टाइम यू गो टू सी अ फिल्म फर्स्ट थिंग यू डोंट वॉन्ट टू सी दॅट देन हाऊ यू मेक अ पॉइंट इज कम्युनिकेट अ पॉइंट कम्युनिकेशन पॉइंट वी मेड अ फिल्म ऑन सर्फेस कैंसर 25 years ago. I acted in it as a doctor. One of the eminent directors, Gautam Ghosh, made this film. It was called Sham Hi To Hai, which unfortunately nobody buys such film, no? So I have to go and show them. So wonderful scene, I'll tell you. And I'll just tell you how it is because I can't show you. This is a palliative care center. And the treating doctor is teaching the medical students about breast cancer. And a girl walks in who knows her mother is having cancer. Now what happens during this? A phone call comes. And there is a gentleman at the other end. Doctor, will you please come home and see my father? He is constantly saying, and the doctor says, I'm sorry, but it's of no use. He's terminally ill, we are doing everything, and we can see that painless death. And he says, no. So next cut is, you go and you see an old house, old emaciated man on bed, with the whole family surrounding him, right? And the old patient, the moment he looks at the doctor, he is so happy, and he smiles, and he calls him. So the doctor goes very close because he can hardly hear, and what the patient asks, doctor, can I smoke one cigarette? And the doctor looks at you, the last one. So the doctor doesn't know what to do. He looks around, the family says, does anyone has a cigarette? Right? So the son feels the doctor is very tense. So he quickly pack it out, offers a cigarette to the doctor. He asks for the matches, which he also offers. And next shot, the doctor is putting cigarette in the mouth of the patient and lighting. And the whole family said, doctor, you only said that he shouldn't smoke. And doctor said, I know. Next moment, patient takes a deep drag. And in that smoke, a very satisfied face of the patient. Next moment, there is a bout. Shot is cut there. But next time you resume in the palliative care center when he has narrated the story. And the call comes from the son. No, doctor, I just called to tell you my father died this morning. Right? And the mother shouting, why are you telling him? He's the one who killed him. All I can say. So he listens very carefully like everybody. And he says to the students also, why do you think I must have done that? Because when he asked me for the last cigarette, I knew it was not his last cigarette, it was his last wish, which I couldn't say no to. But then what happens is more important. Then he says, but I couldn't help your father, but I can help you. Because when I asked for a cigarette, you pulled out a packet. So obviously you are a smoker. I couldn't do anything for your father, but for you definitely, come anytime we'll check you up. Now how to make a plan? This certainly makes you aware and everything. So how you can identify with, and this communication part is the secret of audiovisual language. And the one bad example is what these documentaries, they create horrible such thing. And the other thing which creates motivation and think about. And the last thing is, if you have to make these kind of motivations, start with the child. That's where sanskar kshamvaya. That's where, now you see in America, the whole complete drop of young generation smoking and drinking. They did it so deliberately now. So, if in that between 6 to 10, if you show them good films, followed by this, then probably when they grow adult, they will know better.
I just think one second. What I was meaning was,
Give us money to make good films.
what I was thinking.
Give tax to make bad films.
So, of course, we don't want films like that. Neither do we want films that show, why don't we make happy films around it? So, what, like your Safar and Anand gave the absolutely wrong message to this community. They showed the absolute dark side of cancer.
What you're seeing about making a point.
Yeah. So, Basically, what we would want are very educated films, but built in a nice story, which brings out the positiveness. Those are our films.
See, this can't be made from intelligence. Otherwise, there's a great difference, but a slight difference between propaganda and education, marketing and awareness. And that's where the skill comes of making the film, and how to write a script and everything. And it's also the duty of society to fund such good films and show them. I've made some good films about other issues, and we'll make this one. But that's a better way of reaching to the masses. What you reach in a scientific community must get across, so that they will tell you, doctor, don't worry, operate me, I'm going to live. That's what. So it should come from within them, and not from your mouth. Counseling is not telling the patient, "Arey kasal kaळजी करतो, काय होणार नाही, काय होणार नाही." It's a useless counseling. The idea of the counseling is, at the end of your conversation, the patient should tell you, "Don't worry, doctor, I'm fine." That's the counseling.
Thank you. Thank you.
ते इन्शुरन्स सारखं नाही, तुम्ही मेल्यावर तुम्हाला फायदा होईल. असलं मार्केटिंग नाही करायचं. So this is very dangerous. Every time you go to see a film, first thing you don't want to say that. And then how you make a point is communicate a point, communication point. We made a film on surface cancer 25 years ago. I acted in it as a doctor. One of the eminent, and see my father. He is constantly saying all that. And the doctor says, "I'm sorry, but it's of no use. He is terminally ill. We are doing everything, and we can see that painless death." And he says, "No." म्हणजे होशा लावलाय त्यांनी, होशा की या. So next cut is, you go and you see an old house, old emaciated man on bed, with the whole family surrounding him, right? And the old patient, the moment he looks at the doctor, he is so happy, and he smiles, and he calls him. So the doctor goes very close because he can hardly hear, and what the patient asks, "Doctor, can I smoke one cigarette?" And the doctor looks at him, "Oh, the last one." No. So the doctor doesn't know what to do. He looks around, the family says, "Does anyone has a cigarette?" Right? So the son feels the doctor is very tense. He won't. So he quickly puts her packet out, offers a cigarette to the doctor. He asks for the matches, which he also offers. And next shot, the doctor is putting cigarette in the mouth of the patient and lighting. And the whole family says, "Doctor, you only said that he shouldn't smoke." And doctor says, "I know." Next moment, patient takes a deep drag. And in that smoke, a very satisfied face of the patient. Next moment, there is a bout. Shot is cut there. But next time you resume in the palliative care center when he has narrated the story. And the call comes from the son, "No, doctor, I just called to tell you my father died this morning." Right? And the mother shouting, "Why are you telling him? He's the one who killed." All right, he said. So he listens very carefully like everybody. And he says to the students also, "Why do you think I must have done that?" Because when he asked me for the last cigarette, I knew it was not his last cigarette, it was his last wish, which I couldn't say no to. But then what happens is more important. Then he says, "But I couldn't help your father, but I can help you. Because when I asked for a cigarette, you pulled out a packet. So obviously you are a smoker. I couldn't do anything for your father But for you, definitely, come anytime, we'll check you up. Now, how to make a point through medium? This suddenly makes you aware and everything. So how you can identify with, and this communication part is the secret of audiovisual language.
Yes.
And the one bad example is what these documentaries, they create horrible such thing. And the other thing which creates motivation and think about. And the last thing is, if you have to make these kind of motivations, start with the child. That's where sanskar-ksham vaya म्हणतात. That's where, now you see in America, the whole complete drop of young generation smoking and drinking. They did it so deliberately now. So if in that bit 6 to 10, if you show them good films, followed by this, then probably when they grow adult, they will know better.
I'll just say 1 second.
Yeah.
What I was meaning was,
Give us money to make good films.
yeah, what I was thinking.
Don't give tax to make bad films.
So, of course, we don't want films like that. Neither do we want films that show, why don't we make happy films around it? So, what, like your Safar and Anand gave the absolutely wrong message to this community. They showed the absolute dark side of cancer.
I told you a scene about making a point.
Yeah. So, basically, what we would want are very educative films, but built in a nice story, which brings out the positiveness. So those are our films I'm talking about.
See, this can't be made from intelligence. Otherwise, there is a great difference, but a slight difference between propaganda and education, marketing and awareness. And that's where the skill comes of making a film, and how to write a script and everything. And it's also the duty of society to fund such good films and show them. I made some good films about other issues, and we'll make this. That's a better way of reaching to the masses. What you reach in a scientific community must get across, so that they will tell you, doctor, don't worry, operate me, I'm going to live. That's what. So it should come from within them and not from your mouth. Counseling is not telling the patient, अरे कशाला काळजी करतो, काय होणार नाही, काय होणार नाही. It's a useless counseling. The idea of the counseling is, at the end of your conversation, the patient should tell you, don't worry doctor, I'm fine. That's the counseling.
Thank you. Thank you very much. It was a pleasure listening to all of you. And I sincerely thank you for enlightening all of us and taking time out and coming here. So we have another panel discussion immediately after this. So I'll ask Hajra, and thank you from bottom of our heart.
This is communication.